Okay, well, this is the second part of chapter 13 from the textbook of radiographic positioning and related anatomy, the 11th edition. This portion of the lecture includes discussion of a double contrast barium enema, the evacuative proctography, or it's sometimes referred to as a defecogram, and the colostomy enema. So a lot of these slides in the beginning will be a repeat of the slides that were used in the first part, where we went into detail exactly how to do everything for a single contrast enema. And honestly, up until the type of tip that's used and the enema bag, a lot of the information is exactly the same as far as prepping the room, prepping the patient, making sure that you have everything available to be able to do that. So some of these slides I might go quickly through because you already should have the information from the first part of this, which is the single contrast BE. So if you miss something or you're unsure, feel free to go back and review that other lecture. All right, a barium enema or a lower GI series. This is to examine the large intestine, and we had discussed before that this can be done with single contrast, meaning just a positive contrast media, or you can do a double contrast study, which includes the positive radiopaque contrast and the negative radiolucent contrast, and that is an image from a double contrast barium enema. As far as the patient prep, we mentioned that it totally depends on the provider. There are definitely bowel cleansing cathartics involved, which is the fancy term for laxatives. They typically have nothing to eat or drink after midnight the day prior, but prior to that, there's usually either a 24 or 48-hour prep involved where the patient is taking cathartics, taking stool softeners, typically only allowed to drink Gatorade, clear liquids, nothing with red dye in it. So no purple Gatorade. You're allowed Jello, broth, typically any no residue kind of diet. No gum chewing, no smoking, and they do have to do an enema the morning of the exam. This slide is from before. The cathartics, like I said, is a synonym for laxatives. There are two types, the irritant laxatives, like the castor oil, that I know it says rarely used. Some old school doctors do still use them. And the second classification of cathartics or laxatives are saline laxatives, like mag citrate, mag sulfate, and things like that. Some contraindications to using them as before are gross bleeding, severe diarrhea, possible obstruction, and any inflammatory lesions. The contrast media does come typically in a single-use closed system kit, meaning that everything you see here, aside from the IV pole, would be thrown out after the exam. The debate about the temperature of the water we discussed in the other lecture, and I feel like if you stick with water that is as close to body temperature as you can get, then that provides the most amount of comfort for the patient. Because you're not going to have it too hot or too cold, and that will help avoid colonic spasm. If there is a lot of spasm, the radiologist or fluoroscopist can ask for us to draw up glucagon, which is a smooth muscle relaxer, and that is only if the patient is not diabetic. You can have topical anesthetic added to the contrast media. That would be in the form of like liquid lidocaine, could be poured into the bag. You can also use lidocaine gel on the enema tip to help the patient, especially if they have hemorrhoids or they're just irritated from being in the restroom pretty much for 24 to 48 hours constantly. Having bowel movements which eventually run out of food, and then it becomes just almost like an acidic bowel movement from the bile. The enema tips, we talked about these before, the acorn tip, a single contrast retention tip. This exam would use a double contrast retention tip. This one is used to inflate the balloon like you see here. This one is used to pump air into the patient with a bulb syringe. Notice the tubing is a little bit thicker on this, and that is because the barium that's used is also thicker to try and help coat the lining of the large intestine. The room prep is pretty much the same as with a single contrast PE. You would set up for fluoro. The table would pretty much stay horizontal until one part of the exam it is raised a little bit to drain some of the contrast. Cassettes, we discussed before that with digital fluoroscopy that is not likely because the capabilities are within the system to take the images. The contrast media still gets prepared by us. We have towels, linens, anything that might come in handy, possibly the compression paddle, aprons for the fluoroscopist, anything that he or she typically requests, we would have available. We get everything ready before the fluoroscopist comes into the room so that when they enter the room, the exam can begin as soon as possible so that the patient can be on their way. The patient typically is on their left side in Sims position, which means the right knee is bent. We have to pull the bucky down to get the bucky slot shield to come out. The fluoro tower typically has the drapes that help protect from scatter radiation. We have a monitor to visualize what we're seeing as the patient is going through the study. The barium bag is kept no more than 24 inches or 60 centimeters from the top of the table. Unless we're directed to do so, that is where it would remain. Sometimes you're asked to raise it. You could also be asked to lower it if the contrast is going in too quickly. This is the footboard we discussed that has a weight limit based on the patient's size. This is what has to be tested to make sure that it's going to stay on the table so that when the patient steps on it, they don't fall. Sims position, which is the position for enema tip insertion, as we discussed. When you're going to insert the enema tip, you want to make sure you're communicating with your patient. You would have 2 pairs of gloves on. You would want to make sure there is as little air as possible in the enema tubing before you begin. And as always, lubricate that enema tip, even if you're not doing it with lidocaine to help the patient with pain from hemorrhoids. You still have to lubricate the enema tip before it's inserted. Enema tip insertion we discussed is up and towards the umbilicus. We never force the tip in. If it doesn't go gently or with slight pressure to pass through the sphincter, then we would wait and request the radiologist to do fluoro while the tip is inserted so that we don't run the risk of rectal perforation. We are allowed to put in 1 puff of air after the enema tip is inserted to inflate the retention balloon so that it stays inside the patient. Any more than 1 puff of air would have to be done while the radiologist is in the room under fluoroscopic guidance. As always, we review the chart to make sure that we know everything we possibly can about the patient before they come to us for this study. If it's an outpatient, that's not really possible to look at the chart, but you do have the capability to do a thorough and complete history from the patient. Like we said, never force the enema tip. The height of the bag should not exceed 24 inches or 60 centimeters above the table. And you want to just make sure that your water temperature when you mix with the barium is not too hot so that you don't scald the mucosa. And it's not too cold so that you don't put the patient into colonic spasm. This next section, we will look at the double contrast barium enema. Last lecture, we looked at the single contrast enema, so we will begin with the double contrast barium enema exam. Typically, on a double contrast study, we are using barium sulfate and room air. Like I said before, we tend to use a thicker barium That way it kind of sticks to the wall of the large intestine, and you're able to distend that intestinal wall by pumping air at the radiologist direction. This two-stage procedure that we're talking about is found on page 518. And how this is done, they go through the process, and it sounds worse than what it really is. I feel like it sounds overwhelming. But what we do is we use two different stages to coat the intestine. So once everyone is prepared and the radiologist or fluoroscopist comes in, they are going to tell us barium on, to which we will repeat barium on. The thick barium would start to fill the left side of the intestines, so it would go in the rectum through the sigmoid colon, and then it would go up the descending colon to the left splenic flexure. At that point, the radiologist will ask us to pump air through the bulb syringe into the bowel, and that will push that barium across the transverse colon to the right hepatic flexure. Once it reaches the right hepatic flexure, the radiologist most likely will ask that the enema bag gets lowered to the ground. And a lot of times what they'll also do is raise the table slightly. They'll raise the patient's head slightly on the table. They'll turn the entire table, I would say maybe 20 degrees towards vertical, and that will help gravity drain that barium that's in their large intestine. Once they're satisfied with how that looks on the monitor, the second stage begins, where you inflate the bowel with large amounts of room air. You do that by squeezing the bulb syringe, and that air or gas moves the main bolus of barium forward, and what it does is it allows the barium to coat or adhere to the mucosal wall. And they tell you that all of this has to be carried out under fluoroscopic guidance, because the air bolus should not get pushed in front of the barium. If the air bolus was to go in front of the barium as it's going down the ascending colon, what can happen is you would end up with what's called an airlock. An airlock is when you get air in the cecum, and once you have air in the cecum, there's no way to displace that air with barium. So if you end up with an airlock in the cecum, you would never fill the appendix, nor would you reflux barium through the ileocecal valve, which means that entire study would be deemed incomplete. Typically, that means the patient would have to re-prep and come back and have the entire exam done again, which I don't think would make anyone too happy, especially the patient. So it's imperative that during the pushing of the air while we're pumping it, that the radiologist watch and make sure that that air does not get in front of the barium. And we have to be careful we don't start to pump so fast that we're not listening to the directions being given to us as far as instilling that air. So again, we don't want an airlock in the cecum. The overheads for a double contrast barium enema are these as follows, and they are in this order. The reason they're in this order is mainly so that you have the most benefit of air being in the large intestine while you're imaging, which is the whole point of this study. So the first two images that are done are a right and a left lateral decubitus, and these are found on page 532 and 533. So we're going to start there, but we do the right and left lateral decubitus first. Remember, decubitus implies it's a horizontal beam and that we are looking for air fluid levels. Then we do our AP axial butterfly, just like we did for the single contrast study. AP, RPO, LPO, the left lateral rectum. So all of these from AP axial through left lateral rectum are the same exact positions, same exact central rays. The only thing that changes is your technique, because now we're on a double contrast study. Then we do a ventral decubitus. And then on this particular exam, you only do a post-evac if the radiologist or the fluoroscopist requests it. If they don't request it, then we do not do a post-evac. On the right lateral decubitus, which is on page 532, we are at a 40-inch SID. Typically, your IR is 14 by 17, portrait to the patient. Okay, so this is portrait to our patient, even though to us it looks landscape. The technique on this would be 90 kVp at 3.3 mass. Your central ray is horizontal, and you are centered to iliac crest and midline. Now that's assuming the patient fits on one IR like this. If they don't, you may be forced to do 2 image receptors placed landscape to the patient with overlap. On this image, what should be visualized is the entire large intestine, so you cannot clip either the side that is up or the side that is down. So remember, this is a right lateral decubitus because it's called by the side down, and it's marked by the side up. So it would use left marker. You can see there are fluid levels right here, and then you can see the air is rising. You can see that in multiple areas. Usually the decubitus, they are looking for polyps. In the right lateral decubitus, they typically would look for polyps in the descending colon, since that is this section right here. And the descending colon is known to typically have polyps, just like in the left lateral decubitus, we would look at the ascending colon. So again, 90 at 3.3. Then we would roll the patient and do a left lateral decubitus. And all they're showing you is that if the patient was facing you on the right lateral decube, it's most likely that their back is to you for the left lateral decube, because one of those would be, the patient would be facing you AP, the other one they would be PA. Nothing changes on this. You're still at a 40-inch SID with a 14 by 17, either 1 or 2, depending on patient body habitus. You're still 90 kVp at 3.3 mass. This is a left lateral decube because that is the side down, and we would mark with a right marker. Both sides of the intestine do have to be demonstrated on this. You need the entire large intestine. And again, on this, they usually are trying to assess the ascending colon to see if there are any polyps. But you can see this is fluid and this is air. Same here, fluid and then the air. So if you didn't know what it was, if you did not know that that was someone's large intestine with barium in it, it really is a pretty and an interesting picture to look at. They're quite interesting. It's just amazing how the barium kind of lines the lining, and you get this outline of the haustra so perfectly, and you can see every little detail in there. You can see the patient's pelvis is here. You can start to see diaphragm right here. Thoracic spine with the ribs. These are posterior ribs. Okay, so typically both decubitus positions are done with a double contrast study. So those would be the first ones, because your intestine, the patient's intestine is going to be the most full of air right after the radiologist leaves the room. It is possible to, if the patient is expelling air as the radiologist is in there, they could ask that in between each overhead image, you instill 1 to 2 puffs of air into the patient so that it remains full of air. You try to tell the patient not to expel the air while they're laying there, but sometimes that's easier said than done. Then we go to our AP axial. This is the one, remember, that is our butterfly shot. That's usually what they refer to that as. And this is the one that there are 4 options to take this one image. They are on 535 and 536, but we're going to go with the AP axial. So the patient is supine. The central ray is angled 30 to 40 degrees cephalic. The CR is 2 inches below ACIS at midline. And the technique on this is 100 at 3.3 or double contrast. This is on page 535. So this is the one we're looking at. And again, we can see how it straightens out that sigmoid colon. It elongates the rectosigmoid region so that you're not visualizing any overlap. Then we would do our AP barium enema, and that is all the way back on page 527. Okay. Patient is lying on their back. The IR is either portrait to the patient, or you would do 2 landscape. Central ray is perpendicular. And if they're on one image receptor, then the central ray is iliac crest and midline. And the technique on this would be 90 kVp at 2 mass. 90 kVp at 2 mass on this double contrast AP barium enema. The entire large intestine is full of barium on this. And again, this is showing a single contrast study. Even though we are talking about the double, it would appear the same way, except that you would have far less contrast media in the patient, and you would have a lot more air in there as well. Then we go into our RPO and LPO, which were the same as they were for the single. These are found on page 530. The technique is the same, 90 kVp at 2 mass. They are 35 to 45 degree obliques. This is wrong, so make sure you change it on yours. 35 to 45 degree obliques. You're still at 40. Your IR would be the same as it's been for the rest of your images according to patient's body habitus. And central ray is perpendicular to iliac crest, and then 1 inch to the elevated side. So we said in the LPO, we're at the level of the iliac crest and 1 inch towards the right from midline. And on the RPO, we're at the level of iliac crest and 1 inch to the left of midline. For both obliques, you do have to demonstrate the entire intestine. And the purpose of the obliques is to open up the flexure of the up side in a PO. So on the LPO, you are demonstrating the right hepatic flexure open, and in an RPO, you are demonstrating the left splenic flexure open. Now, interesting in that we don't do AOs, but if you flip back to 528 and 529, what happens on the AOs is that you tend to open the downside flexure. So in an RAO, you would open the right hepatic flexure. And in an LAO, you would open the left splenic flexure. So it's opposite of the POs. AOs demonstrate the side closest to the IR open. POs demonstrate the side farthest from the IR open. So make sure you look back on 528 and 529 for AOs and 530 for the POs. We then do a left lateral rectum, which is on page 531. There's actually 2 views on this page, and we will do both of these with a double contrast enema. Patient has to lie in a true lateral, meaning hips and shoulders are on top of each other. We are collimated on this one to a 10 by 12 portrait. The technique on the left lateral rectum and the ventral decube as well is 90 kVp at 20 mass. And your central ray is ACES and mid-coronal, or ACES and midline. And we said it does not matter the size of the patient's backside because the rectum is still going to be centrally located to the midline of the patient. In the left lateral rectum, you will demonstrate the rectosigmoid region, and at that point in time, you will still have the enema tip inserted into the patient with the retention balloon inflated. You would go check all of those images and make sure that nothing needed to be repeated. And if you're good on that, then you come back in, and likely the last image you do will be the ventral decubitus, which is this picture right here. This on 531, it's this little inset picture. And this is the only view that will show the rectum free of a foreign body. And it's the only one that will show air fluid levels in the rectum. So the patient is prone. The central ray is exactly the same as it is for the left lateral rectum, except now your beam is horizontal. And you're at ACES and mid-coronal, or ACES and midline. Okay. What you would do before you shoot, you would line everything up. You would give the patient 1 to 2 puffs of air. You would deflate the balloon and slide the tip out. And then you would run and shoot this image. So on a ventral decubitus, you can see where the enema tip was removed from the patient. There's no enema tip in here. There's no retention balloon. That has been removed from the patient. You can kind of see the barium coming out. And you can see an air fluid level in the rectum. So it's the only view that shows the rectum free of a foreign body, and that foreign body would be the enema tip. It's also the only view that shows an air fluid level of the rectum. Once that image comes out, you are likely done, but if a post-evac was requested, then we would bring the patient back in the room after they've gone in the restroom and tried to empty as much as they can, and they would either lie AP or PA. We would still use 90 kVp at 2 mass, and we would take the post-evac image if it was requested. Most of the time, that image is not requested on a double contrast study. Once you are completed, you would give your patient the post instructions, which as always are 8 to 10 glasses of water in addition to what you normally drink until your stool returns to normal color. All right, moving on to the evacuative proctography exam. Okay, evacuative proctography, or sometimes it's called defecography, that is a mouthful. This you will find on page 520 of your textbook. Okay, evacuative proctography or defecography. What this is a functional study of the anus and the rectum that is conducted during the evacuation and rest phase of defecation. Basically, while the patient is having a barium bowel movement, they are able to evaluate the function of the anus and rectum during the evacuation and rest phase. Some of the indications why a patient might have this ordered would include a rectocele, which is basically, it's basically like a big diverticulum in the rectum, and typically the rectal wall is weakened, and then fecal material can drop into that pouch and stay there. And sometimes I'm sure it would be extremely painful for the patient, but a rectocele would be one indication. Rectal intussusception could be another reason the patient might have this ordered, or the patient could also have a prolapsed rectum, where the rectum comes outside of the body. So any of those clinical indications could warrant the patient having the evacuative proctography ordered, or a defecogram. There is some special equipment used in this exam. Typically there's a mobile or portable commode. You can see this picture is in 13.47 on page 520. Typically the patient would sit on this. You can see the toilet seat up there labeled letter E. You can see that this commode is rolled in front of the fluoro table when it is in an upright position. The footboard is not attached, and this is rolled right up so that the patient can sit. They are typically seated in a lateral position, and then when they have that barium bowel movement, it would drop into this red bag, which then could be disposed of, and all this would be recovered, sanitized, recovered, and then we could do another exam. So this fluoro table is erect, the portable commode slides right up, and then the fluoro tower would come around the patient so that they could take these images while the patient is having a barium bowel movement. With this exam, they do use, usually they will use two contrast media. Now in this picture, you can read it and it reads correctly. In your book, they printed the picture backwards, but it's figure 13.48. And typically the patient is given Polar Plus. They're given that to take and drink 2 hours prior to their study at home. Okay. They do tell you that there's high density barium sulfate mixture is required, and some departments actually make their own contrast by mixing barium with potato starch. What that does is thickens the barium and it gives it like a mashed potato consistency. And it says sometimes the normal barium sulfate can evacuate too quickly to allow any detecting of any pathologies. So the Polar Plus is the patient's given 2 cups 2 hours prior to the exam. So that's usually something they have at home. They drink that. If their exam was at 8 a.m., they would drink it at 6 a.m. so that it would pass through the system in time to be imaged. And then that other contrast media you see, the anatrast. Now I know it does look, and it really is a caulk gun, but this does not go in the patient. This is just reusable, okay? Meaning there's more than one serving of anatrast. So what they do, typically they will cut just like a caulk gun, this tip off, and then they would fill this syringe and this tubing with the anatrast. And then this section of the tubing, this D1, would go inside the patient's rectum, and the fluoroscopist would push the anatrast into the rectum before the exam begins. Okay, so this is oral, and they drink 2 cups 2 hours prior to the exam. This is only used to fill this syringe and tubing with the anatrast. And when I ask the radiologist why they use both, they just state that using both of those together makes for a much better study than just using one or the other. During this study, once the patient is seated in that lateral position, usually we try to provide them as much privacy as possible. The monitor is turned around. The fluoroscopist and the technologist are as far away as they possibly can be, and they would center on the patient's rectum, and they would tell them not to have a bowel movement, not to bear down until they were ready. And then what they do is they actually take images while they're straining or bearing down, then again while the defecation is actually taking place, and then after defecation during the rest phase. So they try to get all three phases of that, and they usually are doing that to measure the anorectal angle. Okay, the anorectal angle, and they tell you that has to be demonstrated during the procedure. And what that angle represents is the alignment between the anus and the rectum, and that shifts between the straining phase and the evacuation phase. Okay, so between the straining and the evacuation phase, what happens is that anorectal angle, it represents the alignment between the anus and the rectum. So they measure that angle during the different phases to determine if there's any abnormalities. Right? And the most common position for that exam is a lateral position. The last procedure we're going to look at, which is done probably far more often than a defecogram, and that is a colostomy enema. So a colostomy enema is performed on a patient that has a colostomy. Typically, a colostomy is a surgical formation of an artificial connection between two portions of the large intestine. Sometimes because of disease process or inflammatory processes, they might have to remove a section of the large intestine. And then when they do that, sometimes what they'll do to allow healing is bring the terminal end of the intestine to the anterior surface of the abdomen, and they make a stoma or an artificial opening, and they take that terminal end of the intestine and they pass it through that stoma. Once you have that large intestine coming to the outside or the exterior of the body, you have to have something over that area to catch the contents, basically the fecal material, the liquid fecal material that is going to come out of the intestine. So with these colostomies can be temporary or they might be permanent. If it's permanent, it means that that patient is going to have that colostomy for the rest of their life. If it's temporary, how long is temporary really depends, because sometimes it might be weeks, it could be months. I had one patient that had a temporary colostomy for 18 months before they reconnected the two sections of intestine. When they do go to reconnect those two sections, it is called an anastomosis. Okay, that reconnection is called an anastomosis. That is in the book on page 521. You can see where it says the two sections are reconnected. Fecal material would be discharged from the body through the stoma into the special appliance bag that's attached to the skin. That is this. So this stays on the patient's skin. This right here, that hole is where the intestine would come through, and then this appliance bag attaches to that to catch all of the contents that are eliminated from the large intestine. But when the healing is done and they want to reattach, they perform an anastomosis of the two sections surgically. But prior to that being done, they typically will do a colostomy enema on both ends. The end that comes through here, we will typically put an enema tip or a syringe through and push water-soluble iodinated contrast to make sure that it's open or patent. And then a lot of times they will also put the water-soluble contrast through the rectum to make sure that that end is open. Because the last thing they'd want to do is reconnect those two sections only to find out that one section was blocked. Indications for a colostomy enema would be they can do it to assess for healing, They can check for obstruction, they can check for leakage, and a lot of times the reason we do it is pre-surgically to evaluate because the patient is going to be scheduled for an anastomosis. Okay, so this particular picture here showing a colostomy tip, which really is a single contrast BE tip. They could put that through the stoma, and the fluoroscopist or radiologist could push the contrast and we could take images. Sometimes it's not anything this fancy. They will just take a syringe and put that into the intestine, but realize all of this has to be done under sterile condition because that intestine is brought to the outside of the body, so that is a direct route into the patient. So being clean and sterile and using appropriate aseptic technique is vital for that patient. Once any of these exams are done, whether it's a colostomy enema, a defecogram, or a double contrast BE, the patient must always be given post instructions, regardless of if they've had the barium sulfate as their contrast media or the water-soluble iodinated contrast. The post instructions don't change. It would be 8 to 10 glasses of water to drink on top of what you normally drink until stools return to normal color, because they will be white even with the water-soluble contrast. So once their stool returns to a normal color, they can stop the water intake. And as always, we do not advise patients to take laxatives or increase their fiber. If you do get asked about that, you simply direct them to their physician for that answer, because we are not medically allowed to give them any advice because we don't know the patient history, not to the level that their physician does. All right, well, that concludes chapter 13 lecture. I hope you took good notes, wrote down techniques, and if you have any questions or comments or anything that you are unsure of, make sure to write those down, and next time we meet, we can discuss. And until then, I hope you have a great day. Thank you so much.